of the lecture is obstetric hemorrhages. The main reasons of the hemorrhage in the second half of pregnancy are placenta previa, placenta abruption. If you're talking about placenta previa, this is the abnormal location of the placenta or in close proximity to the internal cervical os. Classification of the placenta previa: complete or total, when the entire cervical os is covered by the placenta. Partial, if the margin of the placenta extends across part but not all of the internal os. Marginal, if the edge of the placenta lies adjacent to the internal os. And low-lying placenta, if the placenta is located near but not directly adjacent to the internal cervical os into the difference of 6 centimeters. As a rule, the main reason of placenta previa, this is abnormal vascularization. Clinical findings should be different. Firstly, the patient, pregnant woman, complains into the painless bleeding in the second half of pregnancy. You would confirm presence of the placenta in the lower uterine segment by ultrasound. And if the woman complains into the bloody discharge in the second half of pregnancy, you need to perform vaginal examination, you should do this vaginal examination, but very careful, and it's better to perform in operation room, because you should remember that vaginal examination should increase possibility of profuse bleeding. Management depends on the amount of the blood loss. If the blood loss in the second half of pregnancy is not more than 250 milliliters, the patient undergo conservative management. Conservative management means prescription of hemostatic agents. Students, nowadays the first line hemostatic agent is tranexamic acid. Please remember this. The initial dose in 1 gram intravenously. You would repeat this dose in 30 minutes, the same one, and as a rule you would obtain the positive result. Don't forget about vitamins for increasing of the vascular strength, such as rutin, ascorbic, calcium. Corticosteroids would recommended in the case of the bleeding from 24 till 34 week of gestation. And usually you would recommend dexamethasone or betamethasone. The general dose of these drugs is 24 milligrams. Pay attention, students. In the case of the bloody discharge, tocolytic agents are contraindicated. If the woman doesn't have any pain, you don't prescribe tocolytic for relaxation, because their prescription increases possibility of bleeding. Tocolytics are contraindicated. In the patients in labor, what are the management of these patients? Students, in 10 pregnancy, 39 week of gestation, undergo cesarean section when complete, partial, marginal placenta previa and low-lying placenta, when the edge of the placenta is present into the level of the internal cervical os, not more than 2 centimeters. If the edge of the placenta attached to the lower uterine segment in the difference more than 2 centimeters, you would perform artificial rupture of the membranes and induction of labor by oxytocin. At any gestational period from 24 till in-term pregnancy, if the bleeding exceeds 250-300 milliliters, immediate cesarean section should be performed in such patients. Placenta abruption, this is the second reason of the hemorrhage in the second half of pregnancy. This is the premature separation of the normally implanted placenta from the uterine wall. There are many patients at risk for placenta abruption. They are maternal hypertension. Don't forget about pregnancy-induced hypertension. Multiple pregnancy. Polyhydramnios, when you have over-distension of the uterus. External trauma. Preterm premature rupture of the membranes. Cigarette smoking. Cocaine abuse. Uterine myoma. Clinical finding depends from the place of the preterm placenta abruption. And if there are two variants of clinical manifestation of this pathology. In the first one, when the placenta separated and you may reveal the external bleeding. When the blood is present, is separated the lower uterine segment and placenta, and the patient complains into the external hemorrhage. The second one, you may have formation of the concealed hematoma when the external bleeding is absent, and the patient complains into the increase of the uterine tone in the areas of the fundus. You have some hemodynamic changes. You have fetal heart rate abnormalities, and this hematoma is revealed during ultrasound examination. That's why external bleeding is not in all cases possible for placenta abruption. Summarized, the main clinical findings are external bleeding, which may be profuse or like small bloody discharge. It depends on the area of the preterm separation. And in some cases, there is no external bleeding. In the case of the profuse bleeding, in the case when you have total placenta separation from the uterine wall, you will, as a result of this, you will have hemodynamic changes and fetal death. Uterine tenderness in the area of the uterine fundus, back pain, fetal distress, uterine hypertonus or high frequently contractions. As I have mentioned, dead fetus in the, when the predominant part of the placenta is preterm separated. As a result of this, you may have coagulation disorders, and in the small area of the preterm abruption, ultrasound is helpful. When you have hemodynamic changes, when you have profuse bleeding, you don't have the time for performance of ultrasound examination, because this is the waste of time. The waste of time means fetal heart rate abnormality, which should be finished by fetal distress and finally fetal death. You're welcome, students. You will have preterm placental separation and external bleeding. All blood loss should be calculated by the nurse, by the doctor, and by the patients. If you have the such diagnosis as placenta abruption, students, placenta abruption needs emergency cesarean section. In some cases, students, when you have the preterm separation of the placenta in the local area, and as a result of this, you have formation of the retroplacental hematoma, which should be seen during ultrasound examination, you don't need to make the diagnosis as placenta abruption. Correct diagnosis in this situation is retroplacental hematoma. In this situation, the bleeding is not severe. The woman would complain into the spotting, and you would reveal this hematoma during ultrasound examination. You need monitoring for such patient. The patient need to be hospitalized in the department for hemodynamic monitoring, for checking of the fetal heart rate, For prescription, the same drugs as in the case of the placenta previa, tranexamic acid, corticosteroids from 24 to 34 weeks of gestation, and careful monitoring for the maternal and the fetal condition. If the fetus is preterm, is immature, you don't need to perform cesarean section. But the correct diagnosis which should be made in this situation is retroplacental hematoma. You should differentiate placenta abruption, which needs emergency, and retroplacental hematoma. You would observe the part of the placenta which is preterm separated after cesarean section into the maternal part of the placenta. Formation of the clot in this area proves presence of the placenta abruption in this situation. Cuvular uterus. This is uteroplacental apoplexy. When you would observe this cuvular uterus during cesarean section in the patients with placenta abruption, you would examine all surfaces of the uterus to exclude presence of the uteroplacental apoplexy, because thanks to the presence of the hematoma between the uterus and placenta, you have the entrance of the blood into the myometrium. And thanks to this, in this area where the retroplacenta hematoma is located, you would observe the blue-colored uterus and a hypotonic uterus. Please remember, during cesarean section, you would observe this uterus, and the main characteristic is blue-colored and a hypotonic. The management in the past was indication for immediate hysterectomy. Nowadays, students, the management of cuvular uterus corresponds with the main steps of the management in the case of the uterine atony. Please remember. And uterine atony we will discuss in some minutes later. You don't need to perform hysterectomy if you will not complication of the atonic bleeding, such as DIC syndrome. Prescription of the contractile drugs and management in the case of the uterine atony. Contractile suture by manual compression, ligation of the main arteries. In detail, some minutes later. The main differential characteristic between the placenta previa and the placenta abruption are present in the next information. You're welcome, students. Generally, the main differential signs is painless bleeding in the case of the placenta previa and pain, severe pain in the area of the fundus in the case of the placenta abruption. Placenta abruption is the onset of the placenta abruption is more rapid, and as a rule, you will have hemodynamic changes. In the placenta previa, not often. And thanks to this, complication is most common of the placenta abruption, such as DIC syndrome, is very rare in the placenta previa. Pay attention to the history, which is present, typical history for the placenta abruption, like maternal hypertension, pregnancy-induced hypertension, trauma, and there is no specific history in the placenta previa. And as a rule, the patient inform you that during ultrasound examination, she had a placenta previa. It proves the presence of this pathology. Hemorrhage in the third stage of labor and early postpartum period. Postpartum hemorrhage is defined as blood loss in excess of physiological blood loss at the time of the vaginal delivery, more than 0.5% from body weight, but not more than 500 milliliters. You should know such term as massive hemorrhage. Massive hemorrhage in obstetrics means hemorrhage which exceeds 1 liter. Postpartum hemorrhage before delivery of the placenta is called as third stage hemorrhage. After delivery of the placenta, and during the first certain 24 hours is called as hemorrhage, as in early hemorrhage in the postpartum period. Early hemorrhage. Mechanism of hemorrhage stopping after placental separation. Uterine contractions. Calibers of ruptured vessels decreases during uterine contractions. Formation of thrombs, especially in the region of the placental site. Torsion of the thin septs in which vessels are situated. What are the main causes of postpartum hemorrhage? They are uterine atony, genital tract trauma, bleeding from the placental site, retained placental tissue, low placental implantation, placental adherence, uterine inversion, and finally coagulation disorders. Predisposing factors for uterine atony. Over-distended uterus, multiple fetus, hydramnios, distension with clothes, anesthesia or analgesia using, exhausted myometrium, rapid labor, prolonged labor, usage of oxytocin or prostaglandin stimulations, foreign amnionitis, and previous uterine atony. Uterine atony is total absence of the uterine contractions into the external irritation. Nowadays, you don't have such term as hypotonic uterus. You have atonic uterus. For prevention of the uterine atony nowadays, the management of the third stage of labor is held thanks to the active. What do you mean? Please, after the delivery of the baby, you try to exclude presence of the third fetus and prescribe 10 units of intramuscular oxytocin. And thanks to traction and contraction of the placenta is delivered thanks to the pulling by umbilical cord. This means active management. It prevents atonic bleeding. You try to do everything in labor to prevent bleeding, and active management is the first step for prevention of the atonic bleeding. But what are the main signs of the atonic bleeding? Firstly is hemorrhage, but blood form clots in the case of the uterine atony. These clots are accumulated in the uterine cavity, and thanks to this, the uterus is enlarged into the size. It's soft and enlarged. Intravenous success immediately, students. You need help. You call for help. You prescribe oxygen because hemorrhage means hypoxic changes. You call laborant for determination of the main laboratory parameters. You check the pulse, you check the blood pressure to know the amount of blood loss and to you need correct prescription of the infusion therapy. Firstly, what you should know, you should prescribe contractile drugs. First line drug agent is oxytocin. 20 units is 1 liter of fluids, 60 drops per minute. It is initial dose and maximum not more than 3 liters of intravenous fluids containing oxytocin. Ergometrin, students, 0.2 milligram, intramuscular or intravenously very slowly. The maximum dose is 5 doses, students. As oxytocin acts into the fundus of the uterus, the ergometrine effect into the lower uterine segment. And finally, prostaglandin, students. Intramuscular 0.25 milligram and maximum 8 dose. Pay attention to the contraindications of these agents. In the case of the ergometrine, you don't recommend this drug in the patient with pregnancy-induced hypertension. And prostaglandins prescriptions are very careful, are contraindicated for the patients with asthmatic changes. Nowadays, the modern strong contractile drug is carbetocin. Is oxytocin analog. 1 milliliter contains 100 micrograms of the carbetocin. It acts in 3 minutes and 1 injection lasts for 6 hours. Misoprostol as prostaglandin acts in 30 minutes and lasts for 6 hours. Iperectum prescription of 800 1000 micrograms of misoprostol. It's effective for prevention of bleeding. As I have mentioned today, tranexamic acid, the best antifibrinolytic drug, 15-20 milligram per kilogram. Initial dose 1 gram intravenously. Remestic as vasoconstrictor, but it used very rare. This is contractile drugs. But you are obstetrician gynecologist. You should do something locally. And firstly, what you should do is manual exploration of the uterine cavity. Is firstly what you should do. By the hand, you irritate the external surface of the uterus. It stimulates the contractions and you would eliminate the uterine atony. Secondly, you should perform bimanual compression of the uterus. In the third place, you would use the balloon tamponade of the uterine cavity. Finally, students, if you observe that you need laparotomy for using another methods of hemorrhage stopping, the patient undergo into the operative theater, but you should try to compress the aorta to decrease the blood supply of the internal female sexual organs. And in operative theater, students, you would.
So in terms of the blood supply to the ovaries, the arterial supply is via the ovarian arteries and the venous drainage is via the ovarian veins. So the ovarian arteries arise just below the level of the renal arteries on the abdominal aorta on either side. So remember, the renal arteries lie at the vertebral level L1, so the ovarian arteries arise just below the renal arteries. And then in terms of the venous drainage, the left ovarian vein drains into the left renal vein, whereas on the right side of the body, the right ovarian vein drains into the inferior vena cava. So remember that these ovarian vessels actually pass to the superior pole of the ovary via the suspensory ligament or the infundibulopelvic ligament. So moving on to the uterus, we're now looking at it from this lateral cross-sectional view. In the last tutorial I introduced you to the various parts of the uterus, including the fundus, the body and the cervix, and I mentioned that it had this flexion over the bladder which we can see here. But what I didn't introduce you to was the different axes of the uterus. So at the level of the internal os, you can see that the body of the uterus is angled forward at an angle of around 130 degrees. So the axis of the uterine body lies at a 125-degree angle to the axis of the cervix, and this degree of angulation is called anteflexion. And then the degree of angulation you get with the axis of the cervix to the axis of the vagina is called anteversion. So normally this is around about 90 degrees of flexion, so it's not shown as sharply angulated in this model here. So you've got anteflexion, which is the axis of the uterine body to the cervix, and then you've got anteversion, which is the angle formed by the axis of the cervix to the axis of the vagina. So just coming over to one of my diagrams again, we're looking at a poorly drawn sagittal section of the pelvis. So anteriorly you've got the pubic symphysis and the pelvic bone, and you've got the bladder in orange and the rectum posteriorly in brown. So just to illustrate some of the positions that the uterus can take. So the normal position is, if I just draw on the vagina here, and then you've got anteversion of the cervix in relation to the vagina, and then you've got anteflexion of the uterine body. So that's the normal or most common position of the uterus. And then another position of the uterus can be to have the anteversion and retroflexion of the uterus. Or you can also get retroversion and anteflexion, or you can get retroversion and retroflexion. So those are some possible positions of the uterus. So in terms of the blood supply of the uterus, it's supplied by the uterine artery. So if I just rotate the model slightly to the side, you can see this artery running along the length of the uterus. So this is the uterine artery, and it arises usually from the anterior division of the internal iliac artery. And this artery actually runs in the base of the broad ligament. And if you remember that I mentioned before, the uterine artery crosses above the ureter. So remember that mnemonic, water under the bridge, to remember this anatomical relationship. So you can see the ureters running underneath the uterine artery to enter posteriorly into the bladder. So as it ascends along the uterus, it forms anastomoses with the ovarian arteries, which you can see above. And it also gives off descending branches which supply the upper vagina and the cervix. So venous drainage of the uterus corresponds to the arteries. So these veins drain to the internal iliac veins, and there's communication between veins that come from the vagina and veins that come from the bladder as well via a venous plexus. So in terms of the arterial supply to the vagina, the arterial supply is from branches of the internal iliac artery. So you've got various branches, such as the vaginal branches, the uterine branches, which I mentioned, and then you've got the rectal branches, the middle rectal branches, and internal branches of the internal pudendal artery, which supply the vagina. And venous drainage is via the venous plexuses, which drain into the internal iliac vein via the vaginal veins. So now you should have an understanding of the blood supply to the organs which make up the female reproductive system, and also have an idea of the different axes and different positions that the uterus can take. So
Now, here is a review of the simple steps for inserting the Cook Medical Bahkri postpartum balloon in the event of PPH following vaginal or cesarean delivery. First, ensure that the uterus is free of placental fragments and assess uterine volume by direct or ultrasound examination. For transvaginal placement following vaginal delivery, insert the balloon portion of the catheter into the uterus under ultrasound guidance, making sure the entire portion of the balloon is inserted past the cervical canal and internal os. If not already in place, a Foley catheter should be inserted to collect and monitor urine output. The recommended maximum inflation capacity of the balloon is 500 cc's of sterile fluid. It's recommended that the desired volume of sterile fluid be pre-measured into a separate container, rather than relying on a syringe count during the procedure. Using the provided 60 cc Luer lock syringe, begin filling the balloon with sterile fluid to the predetermined volume through the stopcock. To maximize the effects of tamponade, most notably to the lower uterine segment, apply gentle traction to the shaft of the balloon to ensure contact between the balloon and the uterine wall. This can be achieved by securing the balloon shaft to the patient's leg or attaching a weight no more than 500 grams. Packing the vaginal canal with iodine-soaked or antibiotic-soaked vaginal gauze applies counterpressure to help stabilize the balloon in its proper position. Connect the drainage port of the device to a fluid collection bag and closely monitor any ongoing bleeding. Also, watch patients' vital signs, as well as pallor, cramping, and urinary output. To adequately monitor hemostasis, the balloon drainage port and tubing should be flushed with sterile fluid to clear any clots that may be occluding the drainage ports. If the balloon dislodges through the cervix at any point, deflate, reposition, and reinflate with sterile fluid. Remember, the maximum indwell time for the balloon is 24 hours. If the patient continues to deteriorate or if vital signs are not improving, then more aggressive treatments should be pursued immediately. Once hemostasis is achieved, the Bahkri postpartum balloon can be easily deflated and removed. Remove any traction and vaginal packing. Deflate the balloon using the syringe and stopcock assembly. Gently retract the balloon from the uterus and vagina and discard. Continue to monitor the patient for signs of uterine bleeding to ensure stabilization. Here is the transvaginal placement and removal procedure again. Please refer to the instructions for use for full procedural details and contraindications. For transabdominal placement of the Bahkri postpartum balloon after a cesarean delivery, many of the same steps are followed. The main difference is how the balloon is inserted. First, ensure that the uterus is free of placental fragments and assess uterine volume by direct or ultrasound examination. Pass the balloon catheter inflation port first through the abdominal incision into the uterus and through the cervix. This technique allows the balloon to be situated in the uterus without potential contamination of the peritoneal cavity with vaginal flora. Have an assistant help guide the catheter through the cervico-vaginal canal until the deflated balloon comes in contact with the internal cervical os. The incision can now be closed, being careful not to puncture the balloon. Once the incision is closed, follow the instructions described previously for post-vaginal delivery, including filling the balloon, applying traction and gauze packing, monitoring the patient, flushing the drain, and final removal. Please refer to the instructions for use for full procedural details and contraindications.
Welcome to our educational video. This video has been developed by MedNav. MedNav is an organization that helps to promote women's and children's health worldwide through education and innovation. If you'd like to know more about our work or indeed support us, please visit this website link.
In this video, we will review postpartum hemorrhage, the definition, the causes, medical treatments, and then focus in on compression and tamponade as ways to avoid hysterectomy in the extreme postpartum hemorrhage. Hemorrhage is one of the major killers of women globally, and the WHO say that 25% of all maternal mortalities are due to hemorrhage. The majority of these will happen in the austere environment. Most of these deaths are preventable in well-staffed, well-stocked units. The definition of postpartum hemorrhage is over 500 ml of blood loss following a normal delivery or a litre following caesarean section. The causes of primary PPH are divided into the 4 T's: tone, tissue, trauma, and thrombin. Tone accounts for 90% of cases when the uterus fails to contract after delivery of the placenta, meaning the failure of the contraction of maternal blood vessels in the placental bed. Trauma related to delivery. This can be perineal, vaginal, cervical, and even uterine tears. Tissue is when a cotyledon of the placenta or membranes are left within the uterine cavity. Again, this inhibits the contraction of the uterus. The 4th T is thrombin, those with pre-existing coagulopathies or an acquired coagulopathy such as DIC after excessive blood loss or abruption. Uterine atony will also become a consequence of excessive bleeding from all other causes of PPH. The initial management of an atonic uterus is medical, but a postpartum hemorrhage is an obstetric emergency, so should be managed in terms of airway, breathing, and circulation with appropriate resuscitation. A urinary catheter is a key intervention in an atonic PPH, as a distended bladder will inhibit the contraction of the uterus and therefore bleeding will not stop. Drugs used in hemorrhage are as follows: oxytocin, which is also known as syntocinon or pitocin, ergometrin, which must not be used in those that are hypertensive. Sintimetrin is a combination of ergometrin and oxytocin, so again can't be used in hypertensive patients. Misoprostol has the benefit of being able to be administered PR. And hemobate, or carbaprost, which should be used in caution with those that are asthmatic. Tissue remaining in the uterus will cause PPH and must be removed to treat hemorrhage and allow uterine contraction. The placenta will need to be removed if it's not delivered spontaneously 30 minutes after delivery. For manual removal of the placenta, ensure the woman is consented, has IV access, adequate anaesthetic, antibiotic cover, and the bladder is empty. Insert a cupped hand into the vagina and follow the umbilical cord to reach the placenta within the uterus. Place your left hand on the fundus of the uterus and, keeping the fingers of the right hand tightly together, find the plane between the placenta and the uterine wall and gently detach the placenta from the placental bed by bringing your closed fingers towards you. Once the whole placenta is detached, remove it through the vagina, using your left hand to guard the uterus and prevent uterine inversion. Check the cavity is empty and cover the procedure with antibiotics and uterotonics. This simple and very effective intervention can prevent women from becoming unstable in postpartum hemorrhage. Insert a cupped hand into the vagina and form a fist in the anterior fornix. With your left hand on the patient's abdomen, compress the uterus between the two hands to compress the bleeding placental bed. If the patient requires further intervention, the next stage is operative with either compression sutures or balloon tamponade. There are many different types of balloon tamponade available. The Bahniy or Cook's balloon, and even the Sengstacken-Blakemore tube. These have been designed especially for uterine tamponade. With these balloons, you fill between 200 and 500 ml of water into the balloon to provide compression on the placental bed bleeding. These can be used if resources permit, but a cheap available alternative is the condom catheter. For this procedure, you will require a condom, a Foley catheter, which will need to be spigoted either with a spigot or a clamp. And you'll also require some Vicryl ties. Insert the catheter into the condom. Tie the catheter in place. You need to ensure that you do not tie the tie too tight, as this will compress the lumen of the catheter. Gently insert the condom into the uterus, ensuring it is completely within the uterine cavity, and then fill the catheter with fluid. As the condom fills with fluid, it will compress the uterine bleeding and the placental bed in a similar fashion to the available uterine balloon tamponades. The available balloon tamponades take between 200 and 500 ml of water, but the condom will take much more. There will be some leaking of fluid. You'll then need to spigot the catheter. As I say, you can use a spigot or even a clamp. To keep the condom catheter in place, you'll need a vaginal pack, and these can stay in situ for between 6 and 24 hours. Whilst the condom catheter and pack are in situ, you must cover with IV antibiotics. After between 6 and 24 hours, you can gently deflate the condom catheter and monitor for any signs of blood loss. Uterine brace sutures can be used to provide mechanical compression of the uterus at laparotomy. For brace sutures, you will need an absorbable suture with a large needle, such as a Vicryl 3931. This has a 65mm 3/8 circle needle. Most obstetricians would use a brace suture after a balloon had failed following a normal delivery. They may use it sooner at caesarean section, as the abdomen is already open. There are two types of brace suture, the B-Lynch or the Hayman suture. The Hayman is used following a normal delivery, and the B-Lynch is used at caesarean section. Insert the suture 3 centimetres below the incision line and make it come out 3 centimetres above. Take the suture over the fundus of the uterus to the posterior uterus and insert a horizontal suture in the lower segment of the posterior uterus. Take the suture back over the fundus of the uterus and insert the suture, again 3 centimetres above the incision, and then to come out 3 centimetres below. Use your assistant to compress the uterus and tie your surgical knot. For the Hayman suture, you insert the suture in the lower uterine segment. Bring the suture back over the uterus and secure it with a clip. Place another suture, again at the lower segment but on the other side. Use your assistant to compress the uterus. And tie both sutures. If you're inserting a brace suture after a balloon has been tried, you will almost certainly break the balloon, so it is worth putting a brace suture in first if you're going to use both techniques. It's important to remember to use an absorbable suture, as non-absorbable sutures for brace sutures have been associated with bowel herniation and ischemia. The use of these techniques, balloon tamponades and compression sutures, can reduce the need for hysterectomies in postpartum hemorrhage. In fact, in up to 90% of cases, you will avoid the need for a hysterectomy.